tempo atrás seria inimaginável nós discutirmos vigilância ativa para pequenas massas renais, pois justamente é sobre, assim que nós vamos iniciar a sessão de hoje à tarde, convidando o Dr. Phillip Pierorazio para falar sobre Small Renal Masses, Active Surveillance and the Current Guidelines. Lembrando que ele é professor associado de Uro-Oncologia da Johns Hopkins e que conduziu o Intervention Surveillance for Small Renal Masses. Então, on behalf of the Department of Urology of the Hospital de Clínicas, I welcome you. Have a good talk.
Thank you very much. Good. You guys can hear me okay?
Yes.
Perfect. Okay. So I'm just uploading the talk, and while I do that, I just wanted to thank Dr. Bertet and Antonio Gorgon for helping to set this up. It's really an honor to share this work and talk to you guys across the world, and it's pretty amazing that we can now do this through the internet, and I'm really happy to do it. I'd also like to thank all the professors in Brazil for sending your residents and colleagues up to Baltimore. It's our pleasure to have them, and this is how these kind of engagements and collaborations happen. And lastly, I'd like to apologize to the interpreters and translators. I will do my best to speak slowly, but sometimes I get excited and can talk a little fast. So I'm going to talk to you this afternoon about active surveillance for small renal masses. Basically what has, I think, become from an emerging management option to now becoming a more established option for the management of small renal masses. Couple of disclosures. None of these are really financial disclosures, but I do sit on the AUA Guidelines Committee for Kidney Cancer. I wrote the guideline statements with the committee members. I've been funded by both the NCCN and a large government agency that basically pulled all the research for the AUA guidelines. So intimately associated and aware of all the data here. So this is a quote I borrowed from a talk Dr. Ballantyne Carter gave or gives about active surveillance in prostate cancer. And in the 1990s, as many of us know, active surveillance for prostate cancer was definitely not well recognized. And we would say probably in the last 5 to 10 years, it has really become accepted as the main management strategy for men with low-risk prostate cancer. And I would say for kidney cancer and small renal masses, we are somewhere between the first and second step here, where I would say it is not widely accepted. It's starting to be criticized, but we're starting to gain traction and really talk about why it's an important management option for our patients. So just to go over our outlines and objectives, first, we're going to review the American Urologic Association guidelines about active surveillance for small renal masses, and we're really going to be talking about solid masses suspicious for clinically localized T1A tumors. We'll talk about the existing data and literature. We're going to understand how the rationale for active surveillance is really understood through the heterogeneous biology of these masses. We will review the current data and outcomes for patients in active surveillance programs, and we're going to learn how to apply those data into our clinical practices. How should we select our patients for active surveillance? And once we've selected them, how do we follow them? And we're going to focus a little bit on growth rates today. So we're going to start with small renal mass biology and really what heterogeneity in biology means for our patients with small kidney tumors. So we know if we look at the percentage of benign tumors removed in the U.S., we know that 20 to 40% of tumors less than 4 centimeters are benign when removed in the United States. That means somewhere between 3,000 and 5,000 patients undergo surgery for a benign renal mass. We also know that 80 to 90% of masses less than 4 centimeters are indolent by grade and histology, meaning these are low-grade benign behaving cancers. That means there's anywhere from 5,000 to 13,000 low-risk tumors that we remove annually in the U.S. We also know there are a number of characteristics that predict malignancy. We know that men are at least 3 times more likely than women with a size-matched tumor to have a cancer. And some new data from the Mayo Clinic, literally just published this month, showed that the rates of malignancy and aggressive pathology increase as tumor size increases and with male sex. So for every size of tumor, men are more likely to have cancer and more aggressive cancers than women. We also know that most small renal masses behave in a benign fashion. We know the rates of metastatic disease are less than 2% for 4-centimeter tumors. It's much less than 1% for tumors less than 3 centimeters. That's based on institutional surgical data, it's based on population-based outcomes, and it's based on our VHL or von Hippel-Lindau literature. Importantly, in the retrospective active surveillance literature, we're going to talk a lot about prospective active surveillance later, we know that tumors really grow slowly on average, and the rate of metastatic disease is low, somewhere between 1 and 2%. We know the bad genes in small kidney tumors. We know that almost all clear cell kidney cancers have a VHL gene, but we know the proportion of bad cancers and bad genes in these tumors. And most importantly, if this is data from SEER, large U.S. cancer database, if you look at patients who underwent partial nephrectomy, radical nephrectomy, non-surgical management for small renal masses, no matter what their age was, no matter what management they chose, no matter what their comorbidity status or age, the death from competing risks outweighs the death from kidney cancer in almost every single group. And so this is the first guideline statement that the American Urologic Association put out that I think is pertinent to our talk today. And it really says that physicians should provide counseling that provides current perspectives about tumor biology and patient-specific risk assessment of sex, tumor size, histology, and imaging characteristics. And we really need to talk to our patients with T1A tumors or 4-centimeter solid tumors about the low oncologic risk of these masses. And that really brings us right into active surveillance. And so if you look in the literature over the last, I would say, 15 to 20 years now, there's over 70 articles. Most of these are original series. There are 2 large prospective cohorts, and there's a number of growing cohorts in Europe. About 2,000 patients with excellent outcomes. Very few patients die of kidney cancer, very few patients develop metastasis, and an adequate or expected overall survival. However, if you look at U.S. data, only 10 to 20% of patients who would be eligible for active surveillance are actually undergoing active surveillance. Most patients are surgically treated, and I would assume it's similar around the world, maybe even lower. And why is that? Well, it's what I call the active surveillance dilemma. We know in most of these retrospective sources there's selection and reporting bias. We know that patients who die of metastatic disease can be lost. We know the follow-up is relatively short. There's no established protocol for surveillance among these studies. And we know that our outcomes are based on patients who have both benign and malignant tumors, patients who get treated and untreated. We have absolutely no biologic correlates or biomarkers. And lastly, we know that the historic recurrence and cancer-specific survival rates are greater than 95%, approaching 100%, no matter how you treat these patients. So it's very hard to prove a difference for active surveillance. With all of those issues, the AUA went on and created 4 statements specifically regarding active surveillance that we can use to manage our patients moving forward. And I'm going to run through those statements and the data that supports them and how we use that today. So first of all, just basics about active surveillance. When I talk to our patients, when I talk to other providers, this is not see you later. Thank you for coming into the office. Your mass is not dangerous. This is a strategy that closely follows patients and their small kidney mass with serial imaging and laboratory tests. We're evaluating for growth or changing in these masses. With each image, we decide the next time interval, the next image that we're going to get. We hope through active surveillance that delayed intervention would not compromise oncologic outcomes. I'm going to show you data that shows that it does not. And we also tell patients that this is highly individualized. While we may recommend 6 months for one patient, we may recommend 3 or 4 months for another patient. Most importantly, shared decision-making is essential and should include formal decision-making tools. And the AUA tried to do this year, and leading to a well-communicated risk-benefit analysis for individual patients. And so, as I said, the AUA tried to come up with a tool for this, and I'm not going to bore you with the details here, but basically it says there are patient, tumor, and management-related risk factors that we should discuss with our patients when we talk about active surveillance and expected management, and the AUA drew a distinction here. Active surveillance is for patients in whom the benefit of surveillance is moderate or significant when compared to treatment, as opposed to expected management, which is really patients who are undergoing observation. These are patients who are not surgical candidates, who cannot go to the operating room, and these are not the patients we're going to talk about today. This is not controversial, I would say, that these patients should not be going to the operating room and that we should watch their masses. So we're really going to focus on active surveillance and patients who can go to the operating room, but who we decide to keep an eye on. And so the first statement from the AUA says that for patients with a small solid or a Bosniak 3 or 4 complex cystic renal mass, especially those less than 2 centimeters, active surveillance is an option for initial management. And you'll notice importantly here, there's no mention of age, there's no mention of comorbidity. It strictly says masses less than 2 centimeters especially can be watched with active surveillance. And why is that? Well, I'm not going to belabor this point. We talked about the low rates of metastatic disease, the indolent behavior. But really importantly, if you looked in the active surveillance cohorts, there's only about a 1.5% rate of metastatic disease. That's 7 patients in the roughly 2,000 patients in the literature. And if you look at those 7 patients, on average, they had 3-centimeter tumors that doubled in size over the period of 2 to 4 years. So these are tumors nobody would really continue to keep an eye on if they were surgical candidates. So 2 more statements that are actually pretty easy and pretty quick to go over. It basically says, number 2 says that physicians should prioritize active surveillance when the risk of intervention outweighs the risk of treatment. That's pretty straightforward. And then on the flip side, in patients who the oncologic benefits of intervention would outweigh the risks of treatment and competing risks of death, these are our young healthy patients, we should recommend active treatment. And they put up some guidelines here, and no one would argue with this. We know that our older patients with limited life expectancies, who have many comorbidities, who have poor renal function, who have small tumors, it's completely safe to watch these patients. On the flip side, young, healthy patients with a long life expectancy who can go to the operating room, want to go to the operating room, or have big, ugly-looking tumors on imaging should go to the operating room. However, the vast majority of our patients don't fit into these black and white categories. They're somewhere in the middle. And so the AUA here says, for patients in whom the risk-benefit analysis is equivocal or unclear, or patients who want to undergo active surveillance, we should repeat imaging in 3 to 6 months, look for interval growth, and consider biopsy for additional risk stratification. So where does all that come from, and how do we assess that? So I'm going to talk first about patient selection, excuse me, and how do we risk stratify patients who are best for active surveillance. So a lot of this data, I'm going to talk about our program. It's called Delayed Intervention and Surveillance for Small Renal Masses, or DISARM. It is an open enrollment registry, non-randomized study that's been open for almost 10 years now, January 1st, 2009. We currently have over 400 patients in our active surveillance, in the active surveillance arm of this program, and they're enrolled concurrently with patients who choose to go surgery. Our median follow-up is now over 3 years, and about a quarter of our patients have been followed for more than 5 years. Obviously, we're reaching some patients that have now been followed for 10 years. When we select patients into our program, our strict inclusion criteria is they have to be adults, solid renal masses. We don't take any cysts in our program, no familial RCC syndromes, and no suspicion of other metastatic cancers to the kidney. And if you look at our surveillance patients compared to our surgical patients, they're on average about a decade older. They have worse health by comorbidity scores, and on average, their tumors are 2 centimeters in size. When you look at our cancer-specific survival, you see that our patients undergoing active surveillance, not a single patient has died of kidney cancer. And really, if you look by intervention, you'll see the only patients in our program who have died are actually 2 patients who underwent partial nephrectomy and had high-grade or aggressive tumors. Importantly, the overall survival starts splitting at about 5 years, where patients in our active surveillance program are starting to die of competing risks. This says we're probably selecting our patients well, and if you look, we probably select our patients well across the board. Our surgical patients undergoing partial nephrectomy and radical nephrectomy have the highest survival. Patients undergoing ablative therapies have an intermediate survival, and patients undergoing surveillance have the lowest overall survival. And if you look at what predicts that, as you would expect, age and comorbidity index are the strongest predictors of outcome. Active surveillance does not predict mortality when adjusting for other comorbidities. So it's really hard to pick out patients for active surveillance. And if you look at the literature, if you look at the 20-plus studies that report on active surveillance selection, nobody gives objective selection criteria, but about 70% of the studies will talk about some composite of patient and tumor characteristics. We've been working on objective scoring systems, and we've gone through many iterations. The most recent one looks at age, tumor diameter, comorbidity index by Charlson, which is very easy for people to calculate, and most importantly, I'm going to point out here, and we're going to talk a little bit about this, physical component quality of life, or basically how a patient reports their own physical health. Our score discriminates pretty well between our surveillance and intervention patients, where you see most of the patients undergoing surgery have low scores and most of the patients undergoing surveillance have high scores. Now, it's a little bit of a self-fulfilling prophecy. This is a retrospective kind of look at our prospective registry, but we got this concept about physical health from SEER data, from large nationwide data, where if you look at a subset of national data that has health-reported outcomes, about 1,500 patients with kidney cancer, you see that a patient's report of their own physical health better predicts their incidence of non-kidney cancer mortality than any other score when controlling for age, sex, and basically a Charlson or comorbidity index. And patients who have the worst survival have the worst physical health. Importantly, if you look at our patients who report the worst physical health actually have about a 50% survival at 5 years, which is much different than the rest of the cohort. And interestingly, if you ask these patients a single question about their physical function, you ask them about their limits with moderate activities like moving a table, pushing a vacuum cleaner, bowling, or playing golf, patients who have trouble doing physical activities are more likely to die of other causes. And so how do we pick our patients? Well, we really say that active surveillance is an initial management option for anyone with a suspicious T1A tumor. It is the primary option for patients of advanced age and with cardiovascular comorbidities, or for anyone with tumors less than 2 centimeters. Obviously, you need to consider operative morbidities, patient preferences, and we're really thinking more and more about patient-reported physical health and well-being. And now some lessons that we've learned about following patients. How do we do this once we've identified them and enrolled them in an active surveillance program? So most of our surveillance protocol now says that we image patients every 6 months for 2 years, and then annually thereafter if their tumor is showing stability in growth or slow growth. We do require axial imaging up front. We want a CT scan or MRI when patients enroll. And every year we get a chest image and we do a complete metabolic panel, basically to do a complete metastatic survey and make sure we're not missing anything. We basically say ultrasound has become our preferred surveillance modality. It's a great way to measure tumors, especially when your ultrasound technicians know where the tumor is and what they're looking for. It is cheap, it has no radiation, and it's preferred by many patients who don't want to undergo repeat ionizing radiation over several years. And what we tell all our patients here, though, is that active surveillance can and should be highly individualized. We may change our time interval based on that patient's health or their tumor. We may alternate axial imaging for surgical candidates. We may use ultrasound only in patients who are at higher risk of surgery. And here are the spider plots or growth curves for about 300 patients in our program. And what you see is, on average, these tumors grow slowly, about 1 millimeter per year. And if you look at kind of the overall growth rates, you'll see that only about 20% of tumors grow greater than 0.5 centimeter per year. The vast majority of tumors, about 80%, grow slowly or don't grow at all. Importantly, if you look within the first year, you'll see the highest growth rates within the first year of surveillance. Not only do you see the highest growth rates, but you also see the highest variation in growth here, and that funnels down or normalizes with increasing follow-up. And why is that? Well, this is due to some variation in measurement, and we really think it's a mathematical artifact. If you consider a spherical solid renal mass, we know all these tumors aren't spheres, but assume that they are. We'll assume a 3 centimeter tumor. And assume if you image that same tumor on the same day using a different technique, you may get it tangentially, you may get it at an angle, which would give you very different diameters. Now imagine you take the same tumor that hasn't grown, image it 3 or 4 months later, take that very small change in size and then extrapolate it, and you could get a very large growth rate over a short amount of time, which really is a mathematical artifact, not really true growth in that tumor. So when we see elevated growth within the first year, we avoid intervention. We often re-image our patients at a shorter interval, and we'll even consider renal mass biopsy in these patients. Now, what about progression and crossover? So we defined progression at the beginning of this trial 10 years ago as any tumor that crossed over 4 centimeters, a tumor that would grow at 0.5 centimeter per year, any patient who develops symptoms, which would be hematuria, without another cause, and any patient who electively crossed over either due to patient preference or changes in health. And what we see is about 75% of our patients have a progression event over 7 years of follow-up. Why is this? Well, if we look at what those progression events are, really importantly, not a single patient has developed metastatic disease, and that would truly be progression on active surveillance. But if you look, about a third of the progression events are patients who have an elevated growth rate but decide not to go to the operating room. And if you look at the rest of the progressions, most of these are patients who elected to go to the operating room, but only half of those were for growth rate. And so if you look at our patients who went to the operating room with delayed intervention, you'll see that they had a higher growth rate, whether you consider their mean growth rate or their maximum growth rate. But importantly, we see no difference between the patients who underwent surgery up front and delayed intervention in their rates of benign pathology and kidney cancer, if they had kidney cancer in their histology grade or stage, or in their ability to go nephron-sparing surgery. And so we really say that delayed intervention in an active surveillance cohort is safe without compromise of oncologic outcomes or nephron-sparing window. And we're not the only people to show this. The group from Fox Chase in Philadelphia just reported 5-year outcomes for their active surveillance program. Their waterfall plot looks remarkably similar to ours. About 20% of patients in their program had growth, and you'll see with a median follow-up of about 5 years now. Importantly, the blue bars in this waterfall graph are patients who went to the operating room. And you'll see tumors that grow, those patients were more likely to go to the operating room. And here is the cumulative incidence of patients who went to the operating room. And you'll see it starts at about 9% at 1 year, and about 40% of patients in their program went to the operating room at 5 years. Most importantly, the cancer-specific mortality was 1%. Even though 40% went to the operating room, only 1% died, and only 1 of 100 patients on active surveillance who did not go to the operating room developed metastasis. So this really leads us to believe growth rate predicts intervention. It predicts our ability to be uncomfortable with these masses and take people to the operating room, but it really does not impact oncologic outcomes. So over the last 2 years, we've really been rethinking what growth rates and what does progression on active surveillance mean. So this is what I do know. We know that about 80% of small renal masses on surveillance will grow slowly or not at all. We know that the growth rate within the first year is an unreliable predictor of the overall growth rate. We know that overall growth rate does not predict malignant biology or metastatic potential, but we do know that it does predict intervention. So I highlighted 3 patients in our program just to highlight some of the important nuances here. And if you look, these tumors don't grow in a linear fashion. In fact, they often grow in spurts. They may grow a little, they may shrink a little. They actually don't grow at 1 millimeter per year, but on average it's about 1 millimeter per year. And what we've really been looking into now is consecutive growth periods. And what you find is if you have a patient whose tumor grows and grows and grows, you will select out patients who have unfavorable pathology. And what this graph shows you here is that the 0 are patients who had no positive growth. You see a higher preponderance of favorable or indolent pathology. Patients who had 1 period of growth, you see about a 50-50 ratio between indolent tumors and aggressive tumors. But if you see tumors that grew at 2, 3, and 4 periods, you're really selecting patients out who have aggressive cancers, high-grade T3 tumors. And so we've really rethought progression. We know by our earlier definition, 75% of our patients will progress. Most of it's due to an elevated growth rate or elective surgery, but nobody dies of kidney cancer and nobody develops metastatic disease. We know that oncologic outcomes, as we talked about for 20 minutes, are driven by tumor size and stage, and we know that growth rate predicts intervention but not malignancy. So we really need to think like we do in prostate cancer, grade and stage reclassification, and perhaps persistent growth in our patients being followed for small kidney tumors. And lastly, I'm just going to finish with some interesting lessons we've learned in about 10 years. We're going to talk a little bit about quality of life. I'll touch briefly on renal mass biopsy, which could be its own lecture. And lastly, I'm going to talk about the disappearing small renal mass. So here's about 5 years of data in quality of life for our active surveillance and primary intervention patients. And what you will see is that patients who undergo surgery have better quality of life across all time points than patients who undergo active surveillance. But if you really delve into this, the graph on your right shows that this is really driven by physical health, harking back to that questionnaire I told you about before. Most importantly, if you look at changes in quality of life, this is mental health. You will see that mental health and quality of life improves for all patients. Patients who undergo surgery and patients who are in the active surveillance program, basically saying that anxiety and depression are alleviated by being in a structured program where patients are being followed on a regular basis and discussing their masses. Here's a really interesting graph. These are patients, this is once again mental health, which includes domains of anxiety and depression, and time zero is when patients had a biopsy. And what you'll see is whether that patient chooses to stay on active surveillance, go to the operating room, or cross over from active surveillance, their mental health, their anxiety, and their depression improves. And so biopsy can be an important adjunct to improve basically the mental well-being of our patients on surveillance. Importantly, this is not all patients. And when we first started the program, we only biopsied about 5% of patients. Now, in the last couple of years, we're closer to 25 or 30% of patients in our program. We don't biopsy everybody, and we do not require biopsy at the beginning, but we offer it to everyone. Well, what do we know about renal mass biopsy? Well, first I would say we absolutely know renal mass biopsy. It's safe. We pulled all of the data for the AUA that's in the guidelines. I'm not going to go through it here, but we know that about 5% of patients will experience a hematoma. That's the highest risk complication, but about 1% of those patients will require a blood transfusion. Tumor seeding does not occur with modern techniques of biopsy. With coaxial sheaths and modern technologies, we have not seen a tumor seeding in the last 10 years. We also know that renal mass biopsy can be performed in a variety of settings. Radiologists, interventional radiologists, urologists, with ultrasound or CT guidance under local or general anesthetic. We are actually now doing these in our urology clinics for our patients who want to get a biopsy. And I would tell you, I was happily surprised to find it's very well tolerated and pretty easy to do. What else do we know about biopsy? Well, we know what we call the positive performance characteristics are excellent, meaning if you find a cancer, you can be very positive that that patient has cancer. But I think renal mass biopsy is limited by three factors. The first is there's about a non-diagnostic rate of about 10 to 15%. We know there's also a negative predictive value of about 70%, meaning about 30% of patients who have a benign biopsy will actually have cancer when you take them to the operating room. But most importantly, biopsy is poorly predictive for patients with high-grade tumors, the aggressive cancers we really want to find. And why is that? And this is just a simple study from our institution. What you see is high-grade tumors on your left, low-grade tumors on your right, and what you see is only that about 40% of high-grade tumors are actually made of high-grade cancer. The majority of high-grade tumors are actually low-grade disease. And what really keeps me up at night is this patient. This patient had 5% sarcomatoid renal cell cancer on their tumor. This is the only patient out of these 32 in this study who died of kidney cancer, and it would be very hard for a renal mass biopsy to find that sarcomatoid component. So my personal recommendations, what we think about renal mass biopsy, we say it's not a requisite for safe active surveillance. We certainly consider it in patients who have growing small renal masses, or if we're unsure of how to manage a patient. So when risk stratification gives us uncertainty, that's when we can use a renal mass biopsy to help push us in one way or the other. And lastly, I would say that renal mass biopsy can alleviate disease-related anxiety and depression in certain patients. And lastly, I'm going to touch on kind of a new concept for us. We pulled data in the last year from about 400 of our active surveillance patients who had about 3 years of follow-up, and we actually found that 22 patients had what we called a disappearing small renal mass, a mass that basically went away on our surveillance. Most of these were small tumors. They were 1 centimeter or less. Most of them were on ultrasound. But importantly, when you looked at the data, and here you see all 22 patients, the red is when their tumor disappeared, the dark blue is if their tumor reappeared. What we see out of 22 disappearing small renal masses, about 13 or 3% continued to disappear through prolonged period. So when we first encountered this, we thought it was imaging artifacts. Small masses, ultrasound imaging, we're just missing the tumors. But you'll actually see about 3% of your patients will have a small renal mass that disappears with time. Is it a benign lesion? Is it an inflammatory pseudotumor? Is this a cancer that the body fights off? We don't know, but it's a very provocative finding that we've noticed with years of follow-up. And so I'm going to finish here with our summary and keep us right on schedule. So Our current understanding of tumor biology makes active surveillance a rational option for many patients with small renal masses, and we would certainly say that selection is based on patient and tumor characteristics. Early statistics from our research and others say that active surveillance is at least non-inferior to primary intervention. There's excellent metastasis-free and cancer-specific survival. We know now that growth rates predict intervention, but not tumor biology, and that we really need to rethink progression. Is it tumor size? Is it growth overall? To be honest with you, we really don't know. And lastly, I would say that the current AUA guidelines support the use of active surveillance in patients with small renal masses less than 2 centimeters, and for those with competing risks of health with small renal masses up to 4 centimeters. This work's done by a tremendous group of people at Hopkins, some of whom are pictured here. I'd like to thank them, and I'd like to thank you for your attention, and I'm happy to take any questions you may have.
Dr. Pierorazio, can you hear me? Are you hearing me?
Yeah.
Oh, okay. Thank you so much. It's a pretty good talk. Now we have up to 5 minutes to ask questions to you, okay? Questões?
Hi, Dr. Pierorazio. Here's Lucas. Thank you so much for the talk. Hi. Just about renal mass biopsies, what do you think about cystic masses biopsies? I know you don't usually put that on your protocol, but what do you think about that?
Yeah, the data is actually pretty clear about cystic renal masses. All of the positive performance characteristics and non-diagnostics rates you can throw out the window for cystic renal masses. It's much harder to get a diagnosis from a cystic renal mass, and I think there's a great systematic review from Lorenzo Marchioni that shows that the diagnostic rates for cystic masses is much lower than it is for solid. The one exception there is you really have to look at these masses. If there's a real solid component that you can target, I think it's completely reasonable to go after that. But those really are Bosniak 4 masses that we know are going to be likely low-grade cystic renal cell cancers anyway. So you can argue the utilization of biopsy there.
Another question. And what about follow-up for Bosniak 3 lesions? Not in the scope of the lecture also, but what do you think about it?
Yeah, it's a great question. When we designed the program 10 years ago, we thought there was enough heterogeneity with solid masses. We did not want to include cystic masses. It was just too hard to figure out what was going on, so we wanted to make a real homogeneous group. We do follow patients with cystic renal masses. My general impression is that cystic renal masses most often are low-grade cancers. And you kind of have that discussion with the patient, and it's the same way we talk about these small renal masses. You more than likely have cancer. You more than likely don't have a dangerous cancer. How do you want to manage that? I do have a little bit of trouble following cystic renal masses because I don't know what the triggers for intervention are. Very rarely does a Bosniak 3 become a Bosniak 4. Bosniak 4s can't become worse. We don't really know what the trigger for intervention is because we know size doesn't matter as much in cystic renal masses as it does in solid. So I actually err on the side of actually taking a lot of cystic renal masses to the operating room because I don't know how to follow these patients yet. I think biomarkers are going to help us here. We're working on some percutaneous techniques and other things to try and predict which of these masses are bad. But right now, I find them more perplexing than I do the solid renal masses.
Thank you, and congratulations for the great talk. Thanks.
Okay, any questions? Okay, thank you very much for your participation.
Thank you, guys. Look forward to seeing you soon.